So today new topic in shock series, that is cardiogenic shock. So cardiogenic shock is nothing but there is inadequate circulation, decreased organ perfusion due to cardiac dysfunction. So what is characteristic feature of cardiogenic shock? It is low cardiac output with adequate or increased filling pressures. Systolic blood pressure less than 90 milliliters of mercury at least 30 minutes. Decreased cardiac output less than 1.8 liter per minute per meter square without support, or less than 2.2 liter per minute per meter square with inotropic support despite adequate ventricular preload. So how ventricular preload is measured? It is measured by using left ventricular end diastolic pressure more than 80 millimeters of mercury, or pulmonary artery occlusion pressure more than 50 millimeters of mercury. We know hypotension presented with cool motor extremities, altered mentation, oligouria, and cardiogenic shock has got highest mortality. So what are the different causes of cardiogenic shock? So we have list of causes: acute myocardial infarction, which causes left ventricular pump failure and mechanical obstruction. So left ventricular pump failure because of large or massive MI, small infarct already in left ventricular dysfunction also causes cardiogenic shock. Mechanical causes include free ventricular valve rupture or cardiac tamponade, papillary muscle dysfunction or rupture, right ventricular infarction, VSD or aortic dissection. Other cause is severe cardiomyopathy with congestive cardiac failure. So causes most commonly dilated cardiomyopathy in alcoholics, or Takotsubo cardiomyopathy, which is also called as stress cardiomyopathy. Acute myocarditis because of infection, toxin, drug, or transplant induced. Myocardial contusion because of trauma or some procedures. Calcium channel blockers, beta blockers. Acute valvular insufficiency because of acute MR, aortic insufficiency. Left ventricular outflow obstruction because of HOCM or aortic stenosis. Obstruction to ventricular filling because of pericardial effusion, mitral stenosis, left ventricular left atrial myxoma. So what is pathophysiology of cardiogenic shock? So basically cardiogenic shock, there is pump failure, and most common cause we know myocardial infarction is there. So there are two limbs. Whenever there is myocardial infarction, so there is systemic inflammation and myocardial dysfunction. Whenever there is systemic inflammation, we see in left limb there is systemic inflammation, increased inflammatory mediators or like cytokines, increased nitric oxide, which causes vasodilatation and decreases systemic vascular resistance. In myocardial dysfunction, there is decreased cardiac output, there is decreased stroke volume, systolic dysfunction is there, diastolic dysfunction is there, and so these three consequences has got different results. So whenever there is decreased cardiac output and decreased stroke volume, there will be hypotension and decreased tissue perfusion, and ultimately compensative vasoconstriction will be there. So in this limb, whenever there is systolic dysfunction and diastolic dysfunction, ultimate result will be myocardial ischemia and progressive myocardial dysfunction and death. So the conclusion is, and there is hampered tissue perfusion, even cardiac perfusion is also hampered, and death is the ultimate result. So how will you manage this cardiogenic shock? So we know cardiogenic shock, in cardiogenic shock, systolic blood pressure is the 90, decreased output cardiac output, which is results in oligouria, pulmonary edema, poor mentation. Initially we must evaluate patient and try to rapidly stabilize it. We must do ECG, which may show MI with ST elevation, or left bundle branch block, a new left bundle branch block, or suspected posterior MI. So initially we follow MONA, morphine, oxygen, nitrates, and aspirin. So initially we must look for hypoxia. If it is persistent hypoxia, we must intubate patient and mechanically ventilate. When systolic blood pressure is then 90 millimeters of mercury, we must start dopamine 5 to 15 microgram per kg per minute. If SBP is less than 80, we should give NORAD 1 to 20 microgram per minute, and our goal should be maintaining my mean arterial pressure more than 65 minutes of mercury. Simultaneously, we should insert an arterial line. So there are two limbs when ECG is positive and ECG is negative. Whenever ECG is positive, so we must try immediate reperfusion by thrombolysis, or we can use IABP. We can do cardiac catheterization when MI is less than 36 hours old, or shock is less than 12 to 18 hour old, and there are no contraindication for anticoagulation. We can apply IABP support. So if there is suitability for revascularization, we can do percutaneous intervention with the stents and epsiximab, and ultimately treatment is CABG. In other limb, whenever there are no ECG changes, we should do 2D echo. We must look for LV RV function and rule out mechanical complications like acute MR, VSD, ventricular wall rupture, right ventricular infarction, pulmonary we must do pulmonary artery catheter monitoring when cardiac index is less than 2.2 liter per minute per meter square, pulmonary capillary wedge pressure more than 50 millimeters of mercury. So it is not a candidate for revascularization, and we must continue dovitamin and milrinone in mentioned doses. And we must label this shock as a refractory shock, and treatment of refractory shock is a left ventricular assisted device and ultimately cardiac transplant. Thank you.